Well, it's my pleasure to welcome back Dr. George Rutherford from UCSF. And we're so grateful, George, for you joining us once again to update us on the coronavirus and what's going on. Thank you.
Sure, Scott, my pleasure.
So this time, after the last interview you did, people had suggested that they would like to ask questions. And so many people wrote into me, and here are some of the questions. So let's get into them.
Okay.
First one, what are your thoughts on recent reports of political pressure influencing the frequently changing directives coming from the CDC, FDA, and other agencies? Are you concerned that a vaccine will be released before full efficacy is demonstrated for political expediency? And do you remain confident that the scientists will remain in control of the vaccine release process as they have for generations of past vaccines?
And that's not a loaded question or anything, is it? So
we'll start out with a good one.
It's a major concern. It's a major concern. And CDC's leadership that I'm very familiar with have been sort of increasingly stand up about all this stuff. Although they, were doing, I think, highly questionable things as early as a couple of months ago, as late as a couple of months ago. FDA has hung tough so far, and NIH has hung very tough. So I think that the likelihood of political interference in the vaccine approval process, there will be tremendous amounts of, don't get me wrong, there will be tremendous amounts of political interference in the vaccine approval process. But I think it will get ignored, and will be and we'll approve this vaccine, or these vaccines. There are 3 in trials, just like we approved other vaccines. And the only thing that could go wrong would be on November 3rd, if it looks like the administration is going to continue, and you face mass resignations, and and who knows who gets put in. And so that would be a bad scenario. But I think, kind of as it stands right now, the way I would see it is that the vaccines will be approved with the same kinds of cautions and levels of scrutiny that have been employed for other vaccines and drugs in the past. So I remain confident about that. I don't know if you saw this, but the FDA said that they were going to require 60 days of follow-up from the second dose. These are 2-dose vaccines, from the second dose of the last person who it was in the trial. Okay, so that's whenever that closes out, plus 60 days. That's what they're going to require, and that would push us deep into December. So, I think the manufacturers are very concerned about the perception of political interference. 9 vaccine manufacturers, there are 11 vaccines in trial. There are only 3 in the US right now. But 9 of the big vaccine manufacturers got together and wrote this extraordinary letter saying that they were not going to release any vaccine until they were personally convinced that it was safe and effective. But safe is the first word. So fingers crossed.
And in terms of rollout of the vaccine, how long is that going to take?
Depends on how many vaccines there are and what the supply is. And I think one thing we can, Operation Warp Speed, to try and get out the vaccines, has done many things right. One of the things is to set up parallel manufacturing processes. So as we're trying to figure out which vaccine to use, we're also worked out the manufacturing processes for each of these 3 vaccines. So the day it's approved, and it won't be formally approved, this will be an emergency use authorization, which is a sort of lower level of scrutiny. The day it's approved, it can go into full-scale production. And then if it turns out it doesn't work and it's not approved, then they just wasted that money. But typically, it would be in series. Now we're doing it in parallel. So I think we'd be able to have quite a bit of vaccine certainly by this time next year. and probably a quarter earlier, I would say. So the way I see it, what I say is that by the end of spring, we'll have focused on, medical personnel, residents of nursing homes, certain essential workers, military. We'll kind of have dealt with that kind of first wave of people. And then we'll start bringing in other people who either have risk groups or are in risk groups, or who are, who are in risk groups, or who are just old, older, not just old. Like I'm in that group. And then it'll go out to sort of more generally. And, who knows what an essential worker is. Teachers, essential workers, maybe. I think the guys picking the fruit in the Central Valley right now are essential workers. It's all, and there are all these issues of equity that run through it and stuff. And I'm glad I'm not on that Institute of Medicine committee. But,
wow.
And in case you hadn't seen it, there's a new risk group that's been established. And I kid you not. It turns out that there's a gene sequence on chromosome 3 that's related to bad outcomes with people who get COVID infection. And it turns out that this gene sequence is a Neanderthal gene sequence. And so, as I pointed out to my wife, whose family is all from Wales, all of whom top out at about 5'3" with red hair, that she can no longer claim that she's not in a risk group. But it's sort of interesting how they can dig into the genetics of this. And I was really surprised. It said that 30% of the population in South Asia, I mean, India, Sri Lanka and stuff, carried this gene. It was 16% European. So
wow.
Fascinating, huh? 0% in Africa, because they all got out, right? They were driven out by the humans those many years ago.
Wow. Now we've got another cautionary tale of who we want to call Neanderthal.
Yeah, be careful.
Be careful.
They got pushed out to the fringes of Europe.
Right.
So it's like the Gallegos in Spain and the Welsh in England, and the Lithuanians and stuff. It's an interesting kind of dispersion. But the marker is red. The marker is red hair.
Oh, go ahead.
Just so you know, you can edit all this out later, I'm sure.
A follow-up question to that came in was, after an effective vaccine becomes available and someone has been immunized, should they, as a senior, continue wearing a face mask in public?
So that's a complicated question, and there are at least 3 factors that go into that. The first is what proportion of the population has been infected. What proportion of the population has been vaccinated? The second is how effective is the vaccine? Those 2 things feed into this concept of herd immunity. And based on outbreaks at places like Avenal and San Quentin and some cruise ships and other things, other kind of closed societies, we think herd immunity lies at around 70%. So if you have a vaccine that's 90% effective, which is pretty unlikely, but let's just start with that. If you say you have a vaccine that's 90% effective and you need 70% for herd immunity, that means you need to have 77% of people vaccinated. Okay? If we're there, we're there. Don't worry, don't sweat it. We're not going to be there, though. There's a lot of vaccine hesitancy. There's a lot of anti-vax stuff going on. And I think that we're going to be lucky to get to 50 to 60% of people vaccinated, and then it's all how good the vaccine is. Now, we can force people to get vaccinated if they work in healthcare facilities, or if they're in schools or in the military, but beyond that, there are not a lot of catch points for forcing vaccination. Personally, I'm going to get the first dose of the first vaccine I can, because I haven't lived 68 years, and looking forward to retirement one day in the next 15 years probably to be picked off by some stupid virus. So I'm certainly going to get vaccinated the first chance I get. Now, the other part of this equation, besides what herd immunity is how much transmission is going on among people who are not vaccinated or who have failed vaccine. That's a real question, because if you end up with half the population unvaccinated and going around and, acting irresponsibly, then, we can have a lot of sustained transmission. We have to get it up to this 60 to 70% level for the virus to gradually disappear. And that's only going to be in the US, right? This is, what happens in Latin America? Nobody has any plans for that, right? We've pulled out of the World Health Organization.
Right.
So, it's still, Fortress America after that.
Wow. Okay. Here's a question. If people are conscientious about wearing masks, maintaining physical distance,
Yeah.
washing their hands, and interacting with others largely outdoors,
Yeah.
how important is it to wipe down surfaces?
Not very.
Okay.
My famous quote at the Berkeley Tennis Club was, "You could lick the bench and not get infected." So, but that's, it's not that big a deal.
Okay.
And I'm sorry, let me just clarify that a little bit. In order to have fomite transmission, which is what you're talking about, that you actually transfer, there's somebody's coughed or sneezed on the surface, you touch it, you rub your eye, you your nose, that is not a particularly efficient way to do it because there are not enough virus particles in that glob. And I say if it's not glistening, you don't have any risk. So, I mean, if you see somebody cough on the subway pole, I would not go put my hand on it, but it's going to be pretty extreme sorts of examples like that.
There was an interesting article in the Atlantic today about R versus K designations that are used, I guess, in immunology, and how the clusters are more key factors than kind of one-on-one measurements.
Yeah.
And what was it, patient 31 in South Korea, who spread or was attributed to giving it to 5,000 people in a mass, I think, church service.
Yeah, I wasn't going to point that out, Scott, but
cluster,
correct.
So the clustering has sort of not been accentuated a lot in terms of people, that seems to be the amplifier in all of this, as opposed to one-on-one transmission.
So in Hong Kong, where they've done a really good job of looking at this, they think that these kinds of clustering events account for maybe about 50% of transmission. And the rest is sort of sporadic. And this gets to the concept of super spreaders. And early on, there was a guy in New York, in New Rochelle, who infected everybody at his synagogue in New Rochelle. And this was early on in March with like 113 people. We thought, oh man, there must be something immunologically wrong with this person, or that they have some sort of defective anatomy, that they keep lots more virus in their nose or whatever. It turns out that it's probably just bad luck, that people are hyper infectious for about 3 days in the course of their illness. On days 4, 5, 6, maybe 7 after exposure. And that's when the spreading goes on. And if you get symptoms, which 60% of people do, symptoms develop on day 5. So on day 4, you're hyper infectious, but with no symptoms. Okay. That's that single day in the course of the illness. If you go out and hang out in bars or other places, with indoors with lots of other people, that's what leads to super spreading events. And I would point out for those of you in the parish who ride motorcycles, that in Sturgis, South Dakota, at the annual Sturgis Motorcycle Rally that was from August 6th to 17th, there were probably 460,000 people who came, 460,000. And of those, there have, at the beginning of September, the estimates were that there were 266,000 secondary cases from that rally. And so that involved multiple people who were infectious over a longer period of time, like a space of about 10 days. And then they went back and transmitted it back from whence they came. And that one motorcycle rally may have accounted for up to 19% of all cases in the United States in the month of August. So, I mean, that's the sort of stuff.
Yep.
That's not like a great idea to go do.
Super clustering. So this also raises the question about
your leather's in the closet. Yeah.
About the testing, because it seemed like Cornell, for example, the Washington Post reported that they have been relatively successful about how their process, which involves testing 3 times a week, and then putting the students who do catch the virus in hotel rooms and paying for that and having a program for that, and they've been able to maintain that. But what about, why aren't we doing this sort of modeling and effort in places, especially like I was some parishioners pointed out, COVID hotspots like 601 and the Imperial Valley.
Well, I mean, so you're absolutely right. This is the way you do it. You screen frequently. You don't have to have the world's best tests. You can screen you don't have to do deep nasal swabs. You can actually do from saliva or anterior nasal swabs. And you don't have to use PCRs. You can use antigen tests. So that's an important distinction to make, is that you can screen frequently with less sensitive tests and achieve the same thing, because they're picking off this period of peak viremia, of peak viral loads when people are most infectious. So yeah, that's the right way to do it. Now, Cornell benefits from having a lot of experience with agricultural and animal husbandry, which is where all this stuff comes from, right? And so it's all about herd health, and that's what that's the kind of term of art that we're using now. So I think that's right, and to the extent that you could compel people to do this, then it works well. I mean, that's what they're doing in the military. That's what they're doing on shipboard deployments and stuff. But if you're doing, if you're going out to, civilian populations that aren't in school, that you don't have a catchment point for, then you have to ask people's permission to do this stuff. You can't really just compel it. We've tested heavily in the Mission District in San Francisco, and we find a lot of people and that go into isolation. But you got to realize that's in San Francisco, where there are programs for housing them. There are programs for social support. There are programs for social support for their families, if they need to do that. And there are programs to replace their income. So if you're a dad, right? Let's talk about dads here. If you're a dad and you happen to get tested, and it turns out you have asymptomatic infection, and your job is to go stand in front of Home Depot and pick up day labor, right? And you get paid day to day. What are you going to do? Why would you go into isolation? You're going to lose income. Your family's not going to eat. It's going to be a big mess, right? That's who you have to deal with, right? Those are the kinds of wraparound services you need to have people isolate successfully. Now, in college, it's not a big deal. You can have some hotel rooms. You can keep a dormitory open. You can really isolate people and quarantine them too, pretty close at hand, and support them. But if you're dealing with people who are doing day labor, which is most of the people in California with this infection, that's where it's really complicated, and that's where I think San Francisco is shown, at least. Shown as an SHONE.
Wow.
Not WN. Yeah.
What's been the biggest surprise to you about COVID? I don't know. So that's a hard question, Scott. I think there are lots of surprises along the way. I think this sort of
this kind of core of non-believers who won't wear masks, who won't try at all, which is a core of about 20%, maybe a little higher, and the entire state of Florida. Those are, I find that so surprising, but it shouldn't be. I mean, there is a large anti-vaccination movement in this country. There are people who are real naysayers about science. It's just, it doesn't matter what you say. We have a perfect solution at hand, which is to give everybody hydroxychloroquine, which, by the way, will give them all heart attacks. All we need to do is pour hydroxychloroquine all over the population, and presto, it's done. You get a lot of amateur sort of, there are a lot of amateurs who dabble in this who waste a lot of time.
Mm-hmm. Mm-hmm. Do you, one question that came in this was, is it safe to hug outside if both parties are wearing a mask?
No.
Okay.
Okay, let me give you an anatomy lesson, and not the kind of anatomy you're thinking of. The conjunctiva, the lining of the eyes, the stuff that turns red when you get pink eye, that's respiratory epithelium. Okay, that has the same lining. It communicates with your nose, your throat, your mouth, your lungs. It has the same receptors the virus attaches to. So, and the masks work as long as you're not coughing or sneezing. If you're coughing or sneezing, the virus can escape. If you get enough force behind it, it'll escape. So, I could paint a scenario where it's, the likelihood of infection is relatively high. On the other hand, it's not going to be, as long as then nobody's sick-ish, and they're not going to talk, because talking is what, as you're expelling virus. Yeah, I'm probably okay. Now, with the exception is unless you're in Switzerland. And in Switzerland, the government has made a pronouncement that grandparents can hug their grandchildren. And a lot of that is predicated on height difference when you actually read the stuff. It's because the kids are short and the grandparents are tall. And, so when if the kids are coughing and sneezing, they're going to cough or sneeze into their grandmother's, knees or waist or something. I'm serious. And so they've actually said that grandchildren and grandparents can hug, but no babysitting, lots of other no's. But it's all about risk mitigation and risk profile.
Someone also asked, speaking about the eyes, that wearing eyeglasses is somehow, someone had read that that's a preventative measure, and I suppose so. It's a mini face mask, but what do you say?
Well, actually, the definitive study came out last week from China. And it was in another city in Hubei province, which is where Wuhan is. And they went and looked at the prevalence of myopia in people who were hospitalized with COVID, and then in the general population. And there was myopia so bad you had to wear glasses 8 hours a day, right? And so by that definition, there were 1/8 as many people in the hospital as there were in the general population. So they thought it had an 8-fold risk reduction with it. Now, CDC would tell you that's not right, and you have to have things on the side of your glasses. They're going to push for the perfect as the enemy of the good. But I was actually quite encouraged by that.
Well, good. Well, thank you so much. These are great questions, great things to think about, and I'm sure the evolution of this time in our world will prompt more questions as time goes on. Maybe you can join us again. You've become, as I say, the Dr. Fauci of St. John's, and it's a tremendous encouragement to have you join us in these interviews. So thank you again, George.
Yeah, Scott, anytime. I'm happy to do it anytime, and really don't hesitate to ask. And if it's not intrusive and it's sort of, something different.
Great. All right. My best to you and your family.
Likewise, and good luck with the fires.
Thank you.
All righty. Over and out. Thanks. Bye.